Welcome to Your Family's Health, the program that focuses on healthcare issues with unique and different modalities for taking charge of your health today. Experts talk weekly with our continuing roster of guests from around the country and right here in Nassau County to keep you up to date on the latest health issues and trends. Take care of your mind, body, and soul. Spend the next half hour with the voice of Nassau Community College, 90.3 WHPC, and get on the journey to better health.
Hello and welcome to Your Family's Health. My name is Dr. Jeanine Cook-Garard from the nursing department here at Nassau Community College, along with my co-host, Vanita Matthias, who is completing her master's degree in nursing education. And today we're talking about breast cancer surgeries and a program called The Hidden Scar. Our guest today is Dr. Shubhada Dhage, Director of Breast Health Program at NYU Winthrop Hospital and their Director of Breast Surgical Services. Dr. Dhage, welcome to Your Family's Health on the Voice of Nassau Community College, 90.3 WHPC.
Thank you. Glad to be here.
So just looking at your role as director, before we get to that, tell us more about you and what made you or prompted you to become a doctor, more specifically to help this population of people.
I love that question. And in fact, that question, part of my question, the answer is going to sound very cliche. However, the answer has actually evolved throughout my career. I've been a breast surgeon now for 11 years. And of course, prior to that, did extensive training to get to this point. I think at an early age, I was very interested in the world of science and the problem solving that's involved with why and what and how do we fix things, which then led me to actually do research at the National Institute of Health because I was lucky enough to grow up in the DC area. From that, I had the experience of shadowing a medical doctor who was doing research at NIH, and that sort of prompted and made me realize that I really loved that interaction with patients and helping people, but also the background behind that of solving the problems and how do we get to better treatments and understanding how disease actually evolves. So that was probably the initiation. But while I was in, as a medical student, of course, while we're rotating on different rotations, I fell in love with the field of surgery and had always been drawn to women's health. A breast surgery seems like the perfect meld of the two, where you're working with women who are facing life-threatening disease. Also allowed me to incorporate my interest in science because I have a background in laboratory research and tumor genomics, as well as then having that touch point of, and what's most important to me in my practice and my role as a doctor is empowerment. Empowering women to take care of themselves, move on from a serious diagnosis, and then become advocates for other women as well.
And it's very refreshing to see that you yourself are a female surgeon, and how what is the percentage of female surgeons are there that are particularly specializing in this area? Is a very small percentage?
Yes. Well, definitely women are underrepresented in the field of surgery. However, I'm very active in the national and international organization of the American College of Surgeons, and I'm very lucky to do so. Through that, we host a diversity podcast, actually, where we highlight initiatives on the front and the entire group to put forward underrepresented minorities as well as women and address issues of bias and how patient care can be improved by making sure we're infusing diversity, not just women, but everybody.
Yeah.
We have to make sure that our population is represented in the doctors that they see as well.
So tell me, I know there has been an increased propensity for women to have breast cancer. Tell me the percentages and how that's changed over the years with men and women.
Yeah. Well, the the average risk of breast cancer is about 11%. And what that translates to is 1 in 8 women will develop breast cancer by the age of 80. Men as well are at risk of breast cancer, but they're most likely to get it because of hereditary diagnosis, a hereditary disease, meaning it's related to the genes that they inherited from their mother or father, where it's not so much so with women, where the risk of hereditary breast cancer is about 10%. So the majority of women who get breast cancer actually get it from a mesh of environmental factors and self-risk factors. The incidence of breast cancer has decreased slightly. And we're not exactly sure why, but one can infer, but not directly link, that we've had an improvement in the methods of detecting breast cancer. However, that's a caveat because we're also detecting early cancer much earlier, so that can translate to better outcomes, but we're also detecting early breast cancers that might not even need to be treated. So hence the conundrum of when to start, screening and when is appropriate. But the overall incidence has decreased.
So tell me about the prevalence of breast cancer on Long Island particularly. It used to be thought that it is more prevalent on Long Island.
Yes. In fact, in the early 2000s, there was a study done by the University of Columbia University where they looked at particular environmental and risk factors, and they were unable to show that there was a propensity or a location or a zip code or a certain environmental exposure that linked women to having a higher incidence of breast cancer. So I think many of the physicians who treat women on Long Island feel that there is a higher incidence, but we haven't been able to actually prove that. But I can tell you from my own experience, which is now in comparison to working in Manhattan for the last 10 years and now working here at Winthrop for the last year, we do see a large group of young women with breast cancer. And we're not sure why, but again, not proven, not directly a scientific basis or proof for it, but it's certainly an inference, or a feeling.
So it's not geographically pointed towards one area, but is it, would you say that it's more prevalent among socioeconomic classes?
Well, I think there's Long Island and then there's the country. Right. And so saying that there's something specific on Long Island, again, there's no direct way. There's no direct link. Okay. But what is important for people to understand is that while the incidence of breast cancer overall has gone down, we know more about specific populations, and we call that category disparities. And disparities, I don't like that terminology because it feels disparaging, and it seems to segregate our thought process. However, I think it is important to highlight the fact that if you are an African American woman, while the incidence of breast cancer is lower in this particular population, the risk of having a more aggressive form is higher. This is why, no matter who you are or where you are or whatever socioeconomic group you come from, it's important to get screening.
There are so many new treatments for breast cancer. Can you tell us over the past 5 years, what are some of the advances to those treatments?
I think that I could spend a whole day on, but certainly I will highlight because I think that we are in an era of change and it's exciting for women. What used to happen, or what we used to think, was that more is better. And that was across the board. That was across the board for medicine. That was across the board for surgery and for radiation therapy. But we're getting smarter. And what I mean by that is that we used to think about these medical treatments in isolation. And let me just step back a moment to just explain why we even have those treatments, and allow me to do that for a second.
Sure.
When a woman has breast cancer, we have 3 goals okay? And one goal is we need to physically remove the cancer. Another goal is we have to prevent this cancer from coming back. And the third is that we have to prevent the cancer from spreading. Hence the three modalities to interact, to synthesize, to create the best outcome for every single patient. Now, that's why when I say we used to think more was better, everyone used to get pummeled with all of this, okay, including extremely aggressive surgery where women would have what was called radical mastectomies, which was, especially for the nurses who saw these patients post-operatively, it was quite debilitating and extremely disfiguring. If you've seen these women. It's quite shocking, and unfortunately, I think many medical students today might not have that opportunity to see the consequences of incorrect treatment. What we used to think was correct, and so women had very aggressive surgeries where a lot of tissue was removed, including affecting their immune system. And their flow of the body, their veins and their immune system, and as well as removing all the tissue. So women were quite disfigured. Now we know actually that less is better, okay? And what I mean by that is that not everyone needs that aggressive form of therapy, and that in fact we should tailor the therapy. We should change the therapy to make it personalized to the type of cancer that a woman has and the person that she is, right? So we're thinking of a more holistic and more personalized, directed approach to the way a patient gets therapy. So we may eliminate radiation, we may eliminate parts of the medicine, or we modify the types and the way that it's performed and done.
So we kind of ended with the choice of treatment. Tell me about the new surgery, the hidden scar approach.
Sure. The hidden scar approach is not necessarily a term for surgery, but it's a method that you can coin, or you could call, or you could just call using a more sensitive to body image approach. And that's what sort of the idea of hidden scar is. The idea behind that is that we're not just thinking about, okay, let's remove this tumor and just take it out. The approach sort of is incorporating this idea of self-image and what's important, right? So ultimately, you want the best cancer therapy, right? And you need to have that tumor removed. But at the same time, as a young or old woman, no matter who you are, you care about your appearance as well. You care about how you feel. You care about how you look in your clothing. And these aren't things that were taken into account as much, although they were taken into account. But thinking about new ways to incorporate self-image and that importance into the whole way of healing has created more awareness. So hidden scar is an approach where you might try to create a scar in a location where it's not as visible. It's also an approach where we call and do what's called nipple-sparing mastectomy. So traditionally, when we do what's called a mastectomy, meaning complete removal of the breast, you may actually your approach might be to go through a cut that's made around the nipple. And so you're removing the nipple. And the idea behind that was that behind the nipple, there's actually ductal tissue which can transform, right? But we know that in certain groups of patients with certain types of cancers, the approach where we can leave the nipple in place, therefore cosmetically, the appearance is much more natural and to the prior state before removal is possible. And that's what hidden scar is.
You're listening to Your Family's Health on the voice of Nassau Community College, 90.3 WHPC. My name is Dr. Jeanine Cook-Garard from the nursing department here at Nassau Community College, along with my student co-host Vanita Mathias, who is completing her master's degree in education. And today we're talking about breast cancer surgeries with Dr. Shubhada Dhage, Director of the Breast Health Program at NYU Winthrop Hospital and their Director of Breast Surgical Services. So are you saying that it's less radical surgery, and now what we're having now, is this incorporating breast implant surgery, or where you move muscle from one location of the body and place it so that you're constructing more of a normal physiologic look?
Absolutely.
It's all about the aesthetics. Is that what we're thinking?
The scar approach?
Yeah,
correct.
the scar approach, right.
The scar approach is certainly for aesthetics, yes. And that recovery and the appearance that a woman has when she's wearing her clothing, not wearing her clothing, who she's around, wearing that bathing suit, all of those are things that we think about. But of course, the primary is always the oncologic approach. What is the safest and what is the best way to remove the tumor? The second aspect of, so the one aspect of breast surgery is removal of the tumor, removal of the breast tissue, and whatever tissue that needs to be removed, right? The second aspect of breast surgery is reconstruction, and that's done by the plastic surgeon. Now, the reconstruction part, which you were alluding to, is whether you use something like a prosthetic, which would be an implant, or whether you use the patient's natural tissue, where we can remove tissue from a different part of the body and move it to the area of the breast to create a natural appearing breast. So those are generally done in conjunction and together at the same surgery. We're lucky to be in a state where there's actually a state law that deems that insurance must cover reconstruction. Nice. Yes.
Yeah. So for someone who is or maybe undergoing a mastectomy, they have no concern or limited concerns, because I know years ago there was a concern about the implants. Now the implants are such that they don't. It's not a side effect of leakage or any of that used to be a concern about.
Well, now there's more options for types of implants. Certainly there is one type that recently the FDA made a recall on, and that's the particular type is a textured implant. But those are not the only types of implants that have been used throughout the years, and certainly not the only ones that are available for women.
What's unique about the breast cancer program at NYU Winthrop?
Oh, we have a wonderful team of breast surgeons, many who are female, many who have had experiences with disease, not necessarily breast disease, but who have a wide range of experiences from treating women. So that's the breast surgery group. But we have all specialty trained radiation oncologists, medical oncologists, social workers, and that patient navigator, all to help with the continuity of care. But ultimately, I think what sets our program apart very much is that there's a personal touch. There's a home, there's a community, and you don't feel like a protocol. You don't feel like you're put on a protocol and you're a number. You have access to the team. And there's the large institution and there's the boutique, right? And we're the perfect meld of both, because we're the boutique where you have someone to talk to all the time. We are lucky physicians where we're given the opportunity to spend the time to comfort and advocate and empower our patients. But at the same time, we have a big name behind us where we still can enroll patients in clinical trials, where many of us, including, the medical oncologist and myself, are doing clinical trials and basic science research with investigators as our whole institution. So it has a small feel, but we have a very big, robust science part of all of it too. And that's what's very exciting about our program.
So, doctor, talk to us about prevention, and when is it appropriate for women, particularly, to go for a mammogram, and what is the correct age, and what is the follow-through with that?
Okay. Well, I'll start with the latter. That's the most controversial, and that's going to vary based on who you see for your mammogram to get that order. And which doctor that is, and which guideline the doctor follows. In our particular institution, we follow the ACR's guidelines, okay, meaning the and ACOG, which are the OBGYN group and the radiology group, which advocate starting your mammogram screening at age 40. Now, what I tell everybody is that in this line of having personalized treatment, we're also trying to personalize screening.
Yeah.
So the first discussion really should be happening at the age of 30 to 35 with your OBGYN or your primary care doctor about when the right time to screen is. And the reason that is because understanding your risks as well to incorporate that into the decision making about when and the frequency and what type of screening to get is very important.
So it may not be just a mammography. It may be that if something is seen, that they will do a needle biopsy or something to really diagnose whether or not there's a need for surgery.
Yes. I think ultimately what's important for you to understand is not just that you have to advocate for yourself regardless of the tool to get screened, but that there are other modalities. And that if there's something abnormal, you do not go to surgery first. You must have a biopsy. And if anyone tells you you need to have surgery first, that's the wrong answer.
That's the wrong answer. I know that we talked about prevention. Tell us whether prevention includes diet. Does it include, I know you talked about genetic predisposition, but what else can we do to prevent breast cancer?
Absolutely, yeah. What are some take-homes, right? Well, I think it's important to realize there's two types of risk factors. There's the genetic risk factors, which you have zero control over, except for being educated, knowing your risk. That is important, and that's where that advocacy for yourself occurs. The second part is the environmental risk factors, or what we call modifiable risk factors, factors which you can change to help decrease your risk of breast cancer. And these are pretty simple, okay? One is that we know taking in about 2 glasses of wine every day for 5 years increases your risk of breast cancer. So you want to drink alcohol in moderation. That doesn't mean you have to stop, but certainly taking in alcohol every single day has been linked with an increased risk of breast cancer. So that's number 1 modifiable. Number 2 modifiable is your weight. Okay? Obesity is linked directly with multiple types of breast cancer, not just breast cancer, and in that list is breast cancer.
Why is that? Has to do with hormones when you are obese?
Absolutely. So there are multiple factors, again, because you have to remember there's no one risk factor that you get and you have and then you're going to get it. You know, it's an interplay of all of them. But certainly with being obese, when you're obese, you have more adipose tissue. And adipose tissue converts to the hormone of estrogen, which means that increases your production of estrogen. And we know increased production, meaning internal estrogen, can increase your risk of breast cancer. So that doesn't mean like eating soy, which people think has estrogen in it, and that's an external factor will increase your risk of breast cancer. We're talking about your internal environment. So fat, being obese, exercise, we know actually reduces your risk of breast cancer. So we say 60 to 90 minutes a week of vigorous exercise will actually decrease your risk of breast cancer.
Now, if you just have a genetic predisposition for breast cancer and you're doing these kind of prevention where you're really watching your weight and you're exercising and you're not drinking excessively or you're not smoking or all of these things that can predispose you to breast cancer, does that decrease, even though you're predisposed, does it decrease your chances of getting breast cancer?
Again, yes, that interplay of genetics with the environmental risk factors. The inference is definitely yes. Because when we talk about genetic risk, we know that genetic risk can even change a little bit with the number of people that you have in your family that have cancer. So yes, it is modifiable, but it doesn't eliminate it. So if you have a hereditary risk factor, meaning you have a gene that you inherited from your mom and dad, or one, that increases your risk of breast cancer, that risk is there. It's a real risk. It doesn't disappear. Nothing makes it disappear.
Is there a test that really will tell me whether or not I have a genetic predisposition for breast cancer?
Absolutely. So one thing actually I'm actually working with the Centers for Disease Control on is that I would really implore women to rethink taking those home kits that you get in the mail, and you test your genes and you determine what your risk factors are. Genetic testing should really be done with a geneticist and with the correct tests that are ordered for you. There's a high level of inaccuracy with those home kits, so please do not use those. Yeah. But certainly if you believe that you have multiple family members with different types of breast cancer, not different types of cancer, it doesn't have to be just breast cancer, you should seek out advice from a geneticist.
Yeah. So how can we get in contact with you? Because you really are dealing with the individual who is at the prevention stage or the surgery stage. What stage should people contact you if they're in?
Absolutely. Our breast program is for the treatment of women who are at risk.
The treatment, okay.
Treatment and prevention of women who are at higher risk of breast cancer. I want to just mention one thing, because I know we're limited on time, is that there's different types of risk factors, and there's one more risk factor which we didn't touch on. So there's hereditary, there's environmental, but there's also a tissue diagnosis, meaning a pathologic risk factor. So if you've had a biopsy and you had a particular type of abnormality, then that itself might actually say, oh, you're at an increased risk of developing breast cancer. So those types of women should certainly be under the purview of a breast surgeon or a breast program, making sure that they are being screened at a more frequent in a frequent way and with different methodologies.
So when you talk about tissue, you really are talking about looking under the microscope at cells.
Correct.
So you would have to get a biopsy in that case.
That's right.
And that's how we're able to determine whether or not it is cancer
or not.
Not.
Absolutely.
Okay. And so how do we get in contact with you?
Sure. The best way is to contact our navigator, who will help any woman who needs who needs access to any one of the types of specialists in our program. And her number is 663-3887. Of course, you can go to the NYU Langone website and the NYU Winthrop website, where we have highlighted everything about our breast program.
Wonderful.
Any parting thoughts that you would like to leave our listeners with?
Absolutely. In addition to the fact that our program is very boutique oriented and we want to take care of every patient from a holistic perspective, I think what's important to understand is that each one of us individuals as doctors have different experiences. Myself, I am a proponent and advocate for young women with breast cancer. I work with the CDC on a national committee to create laws for young women with breast cancer, as well as the Young Survival Coalition. And I'm also a yoga therapist. So that holistic approach exists for every doctor at our institution. But knowing that your doctors are not just doing research, but good treatment, but are also advocating for all of their patients and all women in the country, I think is what makes us unique. One quick parting thing for all women, no matter what, the most important thing for you is to advocate for yourself. If you feel like something's not right, you feel like something's not wrong, but the doctors are telling you, you know what, you're fine, everything looks okay, continue on that path of advocacy until you feel like the situation has been resolved.
Yeah, I think that's very important. Thank you for being here with us today, Dr. Shubhada Dhage, Associate Director of the Breast Health Program at NYU Winthrop Hospital and the Director of the Breast Surgical Services. This is Dr. Jeanine Cook-Garard from the Nursing Department here at Nassau Community College, along with my student co-host Vanita Mathias, completing her master's degree in nursing education. And we want to thank you, our listening audience, for listening to this week's edition of Your Family's Health.
We'd like to get your feedback on your family's health. Send your comments by emailing them to WHPC@ncc.edu. Podcasts of today's show are available on iTunes, Android Podcasts, and Spreaker. This program was produced at the studios of Nassau Community College in cooperation with the Nursing Department. Join us next week for another edition of Your Family's Health on the voice of Nassau Community College, 90.3 WHPC.